Hello, I'm Manoj Karmakar. In this next video, Dr. Michael Barrington from the Oregon Health and Science University in Portland, Oregon, is going to discuss with us the sonoanatomy, the technique, and mechanism of action for the Erector Spinae plane block. If you like any of our videos, do remember to share these videos with your friends and colleagues. Also, if you still haven't subscribed, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
Thank you, Manoj, and thank you for inviting me to a really fantastic meeting. I really admire your initiative and dedication, keeping the theme of the ISSPS alive. My internet connection is unstable, so I hope this does not interfere with the presentation too much. As you mentioned, my topic is Erector Spinae plane block, sonoanatomy, techniques, and mechanisms of action. I would appreciate the Erector Spinae block hit ground running in 2016 and quickly became very popular across a wide range of clinical scenarios for acute and chronic pain in emergency situations, and it became enormously popular. So much so that this journal nominated this block in 2017 as the block of the year, because you can imagine in the field of cardiac surgery and cardiac anesthesia, because of anticoagulation, there are not many options for analgesia. So this block has become enormously popular, enormously utilized, as I said, over a wide range of clinical scenarios. And there's been a large number of case reports, controlled clinical trials, My topic today is focusing not on the efficacy, but on the sonoanatomy, the technique, and how it works. As I mentioned before, the technique was described in 2016, and most of the audience will be fully aware that this was described following treatment of a patient with severe unremitting pain due to a metastasis involving the patient's rib, and the care providers injected between the erector spinae muscle and the transverse process, and as this resulted in quite dramatic improvement in pain relief for the patient, and remarkably resulted in extensive cutaneous loss to sensation involving the entire hemithorax, implying blockade of both the ventral and dorsal rami of the spinal nerves. The technique is very simple, and what I like about it is that the patients can be positioned very similar to that required for a thoracic epidural block. Of course, you do not need to be making markings on the skin. This is really just to teach and demonstrate to the registrars or the residents that the can be reliably located a certain distance, 2.5 centimeters off the midline. Most people would orientate the transducer in a longitudinal fashion and image the end. Practitioners would use an in-plane approach from cranial to caudad, but clearly there are a number of ways that you could perform the block. So the technique is suitable to both a single injection technique and a continuous catheter technique. Very easy for experienced sonographers to locate the transverse process by tracking from laterally to medial, going from the ribs, more medial, then locate the costotransverse junction, and then translate further medial to where the transverse process is imaged, and something a little bit more dynamic, starting laterally over the ribs, imaging in sagittal plane until we locate the transverse process. And this is very straightforward for experienced sonographers, and most of our trainees can do this very relatively simply and efficiently. The technique, as I said, mostly involves a in-plane approach with a needle, impacts on the transverse process, and local anesthetic is injected there. And usually, you get a nice spread of local anesthetic, which lifts up the erector spinae muscle off the transverse process. This technique is very amenable to using a catheter technique, and I recommend that you inject through the catheter to make sure that it is in the best possible position. One thing that I've come to become a little bit wary about is sometimes you think you're in the correct plane, but you may not have advanced the needle as far as you should have. I just give an example here where I'm a very superficial transverse process. What I've tended to do and developed in my practice is to extend the needle over the caudal border of the transverse process, just beyond the transverse process, to make sure I'm in the best possible plane. We'll now get on to mechanism of action. It quickly became advertised as a block that would result in involvement of both the ventral and dorsal spinal rami. This was a result of the original Cadaveric study that accompanied the original clinical description, where the authors stated that there was dye in the vicinity of the origins of the ventral and dorsal rami. This was a very small cadaveric study. One of the most extensive and detailed and informative studies is by our previous speaker, Dr. Yang, and he's already introduced this study to the audience. What I like about this study is that it involved retrolaminar blocks. So it's a relatively large sample. Many of the cadaver studies and many of the case series only involve a small number of patients. Showed quite elegantly that there was limited spread of the dye to involve the thoracic spinal nerves. For example, if you look at the proportion of specimens that were involved with the Erector Spinae injection, where it extended from T5 to T3, it's only 2 out of the 10 injections that spread even 2 segments away from T5. So although the thoracic spinal nerves were involved, and more nerves were involved on average, 3.5 versus 2 with the retrolaminar block, although the thoracic spinal nerves were involved, there was limited spread. But this is the main point I'd like to make. Regardless of the technique, regardless of Erector Spinae or retrolaminar block, most of the spread was posterior. Most of the dye spread posterior to the transverse process, not anterior to involve the thoracic spinal nerves. You can see in the image on the left the deep staining of the Erector Spinae muscle. Both techniques resulted in deep staining of the Erector Spinae muscle. Both techniques spread of dye deep to the extrinsic muscles of the, including the latissimus dorsi and trapezium. Both techniques did not result in clear staining of the costotransverse foramina. The Erector Spinae block primarily had lateral spread along the thoracolumbar fascia, and the retrolaminar block primarily had vertical spread along the lamina. But again, I want to emphasize that in both techniques, the majority of the staining involved the back muscles posteriorly, not the thoracic nerves anteriorly. Dr. Avenizik did a similar study, cadaveric study. As with Dr. Yang, our prime goal was to elucidate the mechanism of action of erector spinae block. Our chief objective was to identify whether, if we did a mock erector spinae block adhering to the normal technical considerations and volumes in a cadaver, whether there would be spread anteriorly to involve the origins of the ventral and dorsal rami. This project involved 10 specimens and 20 sides where we injected 20 mils of injectate that contained 0.5% methylene blue. This study demonstrated extensive spread of the dye cephalocaudad and laterally. Again, posterior spread was predominant, and it involved the muscles of the extrinsic muscles and the back muscles, the extrinsic and intrinsic muscles of the back. There was quite extensive spread laterally. The spread laterally was probably contained by the iliocostalis muscle. But in some cases, the spread, just go back to this image, was so lateral, it went as far as the attachments of the serratus anterior muscle. So there was extensive spread, lateral and cephalocaudad, following 20 mils of injectate. However, only 1 out of the 20 injections was there spread of dye to involve the ventral ramus, and this involved 2 levels. In only 2 of the 20 injections was there spread to involve the dorsal root ganglion and the origins of the dorsal ramus. Because of the widespread spread posteriorly and extensive spread to the superficial muscles are involved with an erector spinae block. As a result of this cadaveric study, we are confident to say that the dorsal rami are likely to be involved with an erector spinae block. But because of limited anterior spread to involve the origins of the ventral and dorsal rami, and I'd just like to emphasize that was 1 out of 20 for the ventral rami and 2 out of 20 for the origins of the dorsal rami and dorsal root ganglion. Because of that limited spread anteriorly into the paravertebral space, I don't feel confident to consider this a block involving the ventral rami. Another cadaveric study, and this was a little bit more elaborate than ours, it only involved 4 cadavers where they did unilateral erector spinae blocks on 2 specimens and bilateral on 2 specimens. This was elaborate because 2 of the specimens were sent to the CAT scanner, and the radiologists and the investigators created 3D images in the sagittal and coronal plane and axial plane. And you can see in the top left image, there's extensive spread in the posterior planes, posterior to the transverse process. But the CT reconstructions do not show any spread of dye into the paravertebral space. There's no spread of dye to the origins of the nerve roots. Similarly, 2 of the specimens were dissected, and I acknowledge this is a small number of specimens, but in this dissection also, there was no involvement of the ventral rami following the erector spinae block. They also, from 2 of the specimens, they froze them for 48 hours, and then they did slices to determine the spread of dye. And these are slices that are in the sagittal plane. And in no case was there extension of dye anterior to the posterior border of the bony structures of the spine and torso. The 3D reconstructions show extensive longitudinal diffusion of the injectate along the erector spinae muscle, but with no anterior passage of the contrast. And you can see in this image, there's perfect visualization of all the intervertebral foramina, and the contrast is posterior to the ribs, posterior to the transverse process. So their main findings are wide block of the dorsal ramus, similar to our findings. At least that's what we would predict in the living human. And there was no involvement of the ventral ramus, again, similar to our findings. I'm going to move on to another study. Now, this is a very different study by Adhikari. And this was an elaborate study involving 3 cadavers, and they used magnetic resonant imaging to determine the spread following both erector spinae and retrolaminar. In this study, in contrast to the previous 2 or 3 studies, there was extensive spread of the gadolinium containing injectate into the epidural space to involve the neural foramina space, to involve the intercostal nerves. Because the previous 3 anatomical studies, there was no direct involvement of the dye into the intercostal space. It was confined to the posterior border of the. And here's another image where it shows very clear spread of the gadolinium contained injectate to the neural foramina and to the epidural space. So this study by Adhikari with 3 cadavers, an elaborate study involving MRI imaging, does demonstrate anterior spread to the neural elements following an erector spinae block. And again, this is Dr. Yang's group, and he's introduced this study. But I'd really like to emphasize the novelty of this study. It was a cadaveric study, and one of their goals was to assess the impact of increasing the volume of injectate. If we give a larger volume of injectate, will that result in increased spread of an injectate of anteriorly to involve the neural elements? In this cadaveric study, they also did endoscopic evaluation. I think this is quite neat because they can disturbing the dye. What they found was that increasing the volume resulted in mostly increased spread to involve the posterior muscles and less pronounced spread to the paravertebral space. So we're getting a theme here that with these anatomical studies, that mostly the spread is being documented posteriorly, not anteriorly to the paravertebral space. Although I do acknowledge there are there's variations in the results that have been published, and Dr. Adhikari is publishing different results to the other studies. Now we're going to move on to a clinical study by Dr. Schwartzman, and this study involves 6 patients with severe chronic abdominal pelvic pain. And in their practice in Uruguay, in South America, they offer an erector spinae block to patients with severe chronic pain. The volume of injectate in the 6 blocks was 35 mils. It was actually 30 in 1 and 35 in 5. But anyway, 6 patients, T10 erector spinae block, and they also did MRI imaging from the patients to inject gadolinium-containing injectate. Now, of note, you can see there's quite marked spread of the dye into the erector spinae muscle. It's quite prominent. The staining is unambiguously dense in this study, or case series, I should say. But there's also spread of the dye into the paravertebral space. There's also spread dye into the intercostal space. There's also spread of dye to involve the neural foramina. So this study really shows in human patients who gave consent to have an MRI following their therapy for chronic pain, that the spread of local anesthetic is heading to the neural foramina, the paravertebral space, to the region where you want the local anesthetic to go. Moreover, there was spread of the local into the epidural space, which you can see in the bottom left image with the black arrow. Now, they do acknowledge that there was quite marked variation in the spread. For example, amongst the 6 patients, you can see that in some patients, the spread involves multiple neural foramina, for example, from T5 all the way down to L2. But in other studies, in another patient, there's very limited spread, very limited involvement of the neural foramina. And this variation is concerning, because we want a technique that has a consistent result. Also, there was variation in the involvement of the muscles. So either the intrinsic back muscles, such as the longissimus, or the extrinsic muscles, such as the trapezius. So again, we're seeing variation in the spread. We're seeing variation in the spread of local based on the involvement of the muscle. Now we're going to go on to another clinical study, and here the Erector Spinae block at T5 level mostly, with ropivacaine 0.5%, 20 mils, has been used for severe acute pain. And I've listed the clinical conditions where the Erector Spinae block was used. And quite dramatically, I believe 20 mils of ropivacaine, 0.5%, resulted in 9 segments being blocked. I think this is a dramatic result, or akin to what I would expect with an epidural block. I don't really understand how you can get such large number of segments blocked with 20 mils of local anesthetic. And moreover, there's limited spread, there's limited variation in the number of segments blocked in this particular clinical series. So 18 patients were recruited to this study that was aiming to evaluate the spread, the sensory block that resulted following Erector Spinae block at the T5 level. And the spread involved the ventral rami, because the sensory block there is being measured in the mid-clavicular line. Of note, there were 2 patients out of the 18 where there was no block, so there was a failed block. So no technique is perfect, we know that. So we go to another study, another clinical study, and this is a volunteer study. The previous study was patients who were being treated for acute pain, severe pain, and treated successfully based on the report. Now we're looking at volunteers who agreed to have spinae plane block with 20 mils of ropivacaine 0.5%. This is by Dr. Zhang, and the goal was to evaluate the cutaneous block that would occur following Erector Spinae block. Now, what Dr. Zhang demonstrated was that there was significant loss of cold sensation, but not involving a large number of segments. The segments that were most commonly involved were T6 to T9. There was widespread cutaneous block on the posterior thorax, but there was no extension of the sensory cutaneous block anterior to the posterior axillary line, indicating in this volunteer study that the Erector Spinae block is a block of the dorsal rami and it's not a block of the ventral rami. This is concerning. Just as there's extreme variability in the anatomical studies, there's extreme variability in the results of the clinical studies. The previous study, clinical study, mapped out extensive blockade, 9 segments involving the ventral rami. This volunteer study has much more restricted blocks the dorsal rami. So in summary, I'm confident to say that Erector Spinae block will result in extensive craniocaudal spread. But this spread is mostly posterior. It's mostly posterior to the transverse processes. Of course, some of the local anesthetic spread does penetrate its way anteriorly based on some of the studies to involve the ventral rami, to involve the intercostal foramina, to involve the origins of the spinal nerves. But my observation from our own work and reading the bulk and reading the anatomical and clinical studies is that the extent of the variation concerns me, and I'm more confident to say that this block extends posterior to the transverse process, and there's sufficient evidence to challenge the concept that Erector Spinae block results in blockade of the ventral rami. There's sufficient evidence to challenge the concept that somehow the local anesthetic, which is injected posterior to the transverse process, diffuses anteriorly somehow into the paravertebral space. I think if you want to do a paravertebral block, if you want your local anesthetic to involve the paravertebral space, I think you should do a paravertebral block. So what is the mechanism of action? As I've already alluded to, I'm confident the Erector Spinae block is a block of the dorsal rami of the spinal nerves. So it's going to be effective for treating conditions and surgeries that involve the dorsal rami. Perhaps the local anesthetic injected in this location has an impact on the thoracolumbar fascia, which, as we know, is richly innervated, and somehow that may have some positive effect on how, or be related in some way to the mechanism of action. It's possible, and we noted this in our cadaveric study, spread. Potentially, in some patients, this could get as far as the lateral cutaneous nerve. Also, there could be a systemic effect. A systemic effect is quite likely because of the large dosages of local anesthetic administered with an Erector Spinae block. Finally, the last reason why Erector Spinae block may be effective in some clinical practices. The outcome of interest is pain, and this is the outcome which is recorded in well over 90% of randomized controlled trials in the field of regional anesthesia. Measurement of pain is subjective. The way you ask the question, who asked the question, the style of inquiry influences the response you get back from the patient. Positive treatment expectations have significant effects on the analgesic effects of our interventions. In fact, Dr. Bingle has suggested that this should be taken into account in controlled clinical trials in some way, that this positive treatment effect should be accounted for, because this is a significant confounder. positive expectation effects are particularly strong in the treatment of pain. They're particularly effective when invasive interventions are used. They're particularly likely to be effective when a new technique is enthusiastically endorsed by a group of clinician researchers. I'll finish there. Thank you very much for your attention, and thank you so much, Professor Carmichael, for inviting me.